Our next speaker needs very little introduction. He's the founder of the Orthobiologic Institute. Please welcome back onto the stage Dr. Stephen Sampson.
Thank you, Hunter. It's great to be back on the symposium as a speaker. It's been maybe a 3-year hiatus, so this talk is going to be pretty light, and the goal is just to stimulate some ideas and discussions amongst us later. You can see there's no disclosures regarding this talk. So just want to highlight 5 key factors globally to predict positive outcomes in regenerative therapies. The first one is the practitioner's skill set, which really encompasses how good they are at diagnosing the problem, which is a bit of an art, not always straightforward, how good your procedural skills are, your techniques, your injection skills, how well you communicate what you're doing, as biologics can be quite complicated, and that's an important aspect with the patient, and how much you know, attending meetings, staying up with the literature, and in terms of biology. The next is what cell type therapies you're using. It's hard to keep up with all the products on the market. We often get calls from professional sports teams, and there's new biologics I've never heard of. But in terms of PRP, BMC, lipo, adipose, amniotic, etc. The next is how do we deliver the cells? Do we just do a simple intra-articular, or some of us have called dump and go, where you're in and out pretty quickly? Do you do interosseous if the pathology is more advanced? Do you target the meniscus or periarticular structures that may be involved? And then next would be the degree of pathology. Are you dealing with mild to moderate arthritis or more moderately severe? And then lastly, the patient's ability to heal, or what we call their cellular fitness. In my practice, I would much rather treat an active individual with severe arthritis than somebody who had mild pathology and was generally sedentary. What's that X factor when the patient comes in the room and they ask you, how soon can I get back to my activity? And a light goes on and you realize this is a good candidate. This talk is going to focus on one minute aspect of these 5 key components, which is looking at the BMC in the soup, and further, one component of that, namely the RBCs. So I just want to touch on 2 brief components here, and one is understanding the pathophysiology of osteoarthritis and how it relates to cellular medicine, and then just briefly go over a little bit of the literature, or a couple studies, on the RBC effects on joints and stem cells. So back in the day when we began this, you can see the PRP was dark red, and we hadn't quite known that there are different variations and formulations of PRP. And over time, through literature and patient experience, we began to understand that RBCs may be pro-inflammatory and perhaps unwanted. And so a general consensus amongst the community is when you're injecting PRP in a patient's body in an intra-articular, perhaps that blood shouldn't be red and should be yellow and more plasma-oriented. And we did a study in the American Journal of PM&R, which was a pilot study on 13 patients listed here. And we wanted to bang out a quick study, so we took 13 patients and we did PRP. This was leukocyte-rich, red blood cell-rich, activated by bovine thrombin at the time. And the plan was to knock out a study in 3 weeks, once weekly intra-articular injections, much like the HA protocol. And the problem was, day 2, all the patients were calling back, my knee's swollen, my knee's blown up. And so we realized we had to change the protocol to every 4 weeks, and over time we've learned leukocytes may be pro-inflammatory and there's some debate, but RBC should be eliminated. But what about BMC? I'm sure many of us are still injecting BMC like this in the corner here, that's dark red blood. Intuitively, something felt off for me when I'm infiltrating this intra-articularly. Is this really the best soup? And in the early days of PRP, we used to rationalize we're injecting mostly good and a little bit of bad, but the good outweighs the bad. And so that was acceptable. And we thought in the future we'd be able to break down components of PRP for particular tissue injuries. For example, TGF-beta or PDGF may be indicated for certain pathologies. But really where we've got is isolating some of the leukocytes or the red cells. So just looking at the pathophysiology of OA, there's 3 real components that we're focusing on. It's subchondral bone, the area beneath the cartilage. the synovial membrane, and the cartilage itself. And what we see are there's 3 primary players and several others, and there's this homeostasis or balance inside the joint of breakdown, repair, inflammation, anti-inflammation. And the body's pretty remarkable, and it has the ability to self-repair, but it gets stuck and it can't overcome the injury. And so MCP1, IL-1B, and TNF-alpha are all in loaded concentrations inside the joint. So 48 did a study, and we heard about it in the bone marrow workshops. What's really in the soup? And maybe we need to think about, instead of marketing or calling this a bone marrow stem cell injection, is it really stem cell that's driving the anti-inflammatory effects? Perhaps it's this milieu, including IL-1RA, that's pretty rich and oftentimes associating for some of the patients anti-inflammatory effects. So IL-1RA is an antagonist for IL-1B as well as MCP1, and it can inhibit chondrogenesis of synovial mesenchymal cells. And when you get increased MCP1 in the joint gets locked in this cycle of ineffective repair. And we published a mini review that kind of goes into this talk a little bit more in detail that you're welcome to look at here. So one thing that got me very interested was looking at hemophilia and hemophilic arthropathy and hemarthrosis and really trying to see what happens. And I encourage you all to look at a couple of these papers. It's fascinating because the pathophysiology directly correlates to OA. And so what happens is you get this hemoglobin in the joint that releases iron or hemosiderin that attaches to the synovial lining, thus creating this catabolic or breakdown state. And then these damaged RBCs create free radicals, which load up the IL-1, which is obviously bad for cartilage, which causes chondrocyte apoptosis or cell death. There was a study where the researchers injected whole blood intra-articular into a human knee, and within 4 days, they demonstrated decreased proteoglycan content or damage to the cartilage matrix. 4 days is the typical time when you get a hemarthrosis from trauma that it takes the body to metabolize it. So whenever you have a reactive effusion in blood in the joint, something bad is occurring internally. And interestingly, there was a study on beagle dogs where they injected the dogs with autologous blood twice a week for 4 weeks. Then at 10 weeks, they looked at the joint and the cartilage, and they found clear joint cartilage damage in the dogs that were allowed to bear weight. Interestingly, those that were restricted with weight, despite having the whole blood, did not have cartilage damage. Here's a study in cardiology used in acute MI, and they demonstrated a dose-dependent negative effect on RBCs on bone marrow mononuclear cells. The cell viability, as you can see on the graph, was directly affected by greater doses in RBCs. Stem cell potency, their migratory and CFU capacity was inhibited, as well as their mitochondrial potential, which is a key factor for stem cell competence or well-being. These are just a couple studies, but should get us thinking, perhaps, why are we injecting bone marrow-rich RBCs? Well, one of the problems is the limited technology in 2018. Most of the commercial systems available and the manual techniques, we can't quite isolate this buffy coat monocyte layer without getting a little bit of RBCs. If we go the other way and we try to eliminate all the RBCs, we take out a lot of the beneficial proteins and regenerative cells. So a hypothesis would consider that if we can remove the RBCs to greater percentages and maintain the monocyte fraction, we could reduce some of the catabolic cytokines inside the synovium with OA and R injections. We can decrease some of the free radicals and prevent chondrocyte apoptosis. Getting back to the early days of PRP, well, most of it's really good, but some of it's not so good, but the good outweighs the bad. And we want to protect the cartilage matrix. Just lastly, a few points here, future directions, questions, and goals, is how do we as a group shift to the next level from just improving patients' pain scores and function to true tissue regeneration? The holy grail, regenerating the cartilage, regenerating subchondral bone, in addition to functional improvement. And this was just a case that was interesting. A real case in our office was an Olympic heptathlete, and she had a cartilage defect, as you can see, with bone edema of her medial femoral condyle. Multiple specialists, high-level athlete, was told stress fracture, rested, waited 3 months, returned to play. In our practice, we work with orthopedic surgeons, and it was eye-opening for me to start looking intraoperative, and you can see this giant hole inside her knee. And that's what the cartilage defect looks for those of us not in orthopedic surgery. So how do you expect to inject an intra-articular PRP in this patient and hope that she's going to compete for our country in a gold medal? So you got to be creative and merge some minimally invasive biologics, whether it's interosseous, scaffolds, de novo, et cetera. What's really in the BMC soup that's driving the change? I'm convinced it's not the MSCs. If you look at the presentations, 0.01%, that's really low. But why do many of us feel that BMC and adipose go hand in hand as far as clinical benefits? It's that anti-inflammatory cytokine soup loaded in IRAP and other proteins, I believe, responsible for change. And then, do we activate BMC? No one really talks about that. It's possible to. Do we clot it? Do we trigger more growth factor initially? How do we deliver the cells? Do we do interosseous through arthroscopy injections? And lastly, a couple points, as you're going to see in the banners up there, standardization. We all need to be getting somewhat in sync with how we approach using these cells instead of the Wild West. And then collecting registry data, we'll hear a lot more, is going to be important to shed light on these different cell variations and true clinical outcomes. Thank you very much.